I believe that most implants are not placed in ideal receptor sites. And then also, that may mean that many implants are not placed ideally, and we've just seen a number of examples of that. And so complications can occur, and a lot of what we're going to discuss is how we can avoid some of these complications, and is a digital world the framework that allows us to be able to avoid complications? Well, when you take a look at a situation like this where an implant was supposed to be placed in a sinus elevation in an augmented site and missed the bone completely, well, today we're using technology to look at our mistakes and to see what kind of complications had occurred. So we can use some of the wonderful segmentation properties of some of the advanced software applications that we have, like Simplant, that allows us to be able to segment out some of the anatomical landmarks and be able to see that, in fact, the implant missed the bone entirely and is actually sticking out through the facial plate of the bone. So the augmentation procedure is a failure. The implant had to be removed. And as we can look at the different segmentation properties, some of the other speakers have already talked about, you can see how the implant missed its target. So it's not just about planning, it's about being able to execute the plan. And as we can see, where we have the concepts of 3D planning, we've seen some information already today. I'm going to try to touch on other things. But to me, what 3D planning means is not a bunch of beautiful pictures. It's not a bunch of wonderful illustrations, but it's understanding that the goal of implant dentistry is the tooth that we're replacing. And we've seen some beautiful examples of that already. And if we don't understand how to utilize digital technology to know where the tooth is supposed to be, to understand where those anatomical landmarks are, then we're not going to be able to thrive. We're not going to be able to replace all of the entities that are missing and be able to have a very nice cosmetic and aesthetic result. And again, I want to thank James for all of his work with creating a wonderful audiovisual presentation for us all today. Now, I see in the audience that we have several past presidents of the Academy of Osseointegration. I know at least 3 that I saw, and there may be more that I missed. But here, let's take a road back in time, 1995. If you think digital technology is new, here I am on the main podium at the Academy of Osseointegration in 1995, 16 years ago, talking about this revolutionary software. Happens to be Simplant. And in fact, during that time, I went to Dentsply and said, you know, I think you guys should buy this company. So it's amazing how things happen. And what we were talking about back then was how we can plan to place implants utilizing 3-dimensional tools. I came up with this triangle of bone concept back then. It was first published in 1995. And as you can see, we're identifying a zone, which I'll explain a little bit more later. 1996, I was followed by some other interesting technology as well. As the industry has expanded, we started to look at the EAO meeting, in combination with AO in 1996 in Amsterdam, the fact that we need radiopaque templates. And Marcus Abud talked very nicely about some of those concepts. And here I am 15 years ago talking about the use of a radiopaque template to be able to understand the relationship of the tooth to the underlying bone. This is a template that needs to be made before the scalpel touches the patient, before we take the scan. And of course, this was before we had cone beam CT. This was with regular CT technology. And so when we're looking at the different views that we can see utilizing this type of digital technology, it's important that it's not just about pretty pictures, it's about understanding where we're going. And as William James said, in a famous quote, a new idea is first condemned as ridiculous and then dismissed as trivial until finally it becomes what everyone knows. That's, I hope, where we are today. 1997, again, I was invited back at the Academy of Osseointegration. This time we're talking about bone grafting. And if you follow the history of Simplant and its evolution over time, you'll know that now there's a bone grafting module, and we were just dreaming about this 14 years ago. And so I'm sure you'll see some wonderful stuff from Michael Picos, who will be presenting right after me. And so having the opportunity to be able to do this doesn't mean we have all the answers. The answers lie in understanding restoratively driven implant dentistry. And then we have to coordinate this with the industry partners and all of the other companies. Of course, Facilitate is under the Astra umbrella. It's only Simplant under a different name. And you only need you do not only need the software, but you need the hardware that goes with it to link the parts and pieces from the planning to the execution of that planning. And so there are many, many companies that are involved in guided surgery, and as you have seen from Marcus's presentation, we don't have all the answers yet, but we're working towards those answers. And it's a combination of software and hardware that will allow us to do it. So I'd like to talk about concepts today, and those concepts revolve around how we do things. Ideally, it would be nice for every case, if we're going to do cone beam CT, that we have a radiopaque scanning appliance before the scan is taken. That would be ideal. Does it happen in real life? Of course not. But it would be ideal. And then we can use the cone beam CT software that may be existing on the machine itself. You saw several examples from Marcus of different machines. And then a lot of people will go directly to the surgical intervention. Well, that's one way to do it. The ideal way to do it would be to take that data, be able to convert the DICOM information, and be able to port it into an interactive treatment planning software such as Simplant. And being able to do that allows us an enormous amount of tools. But let me be the first to also tell you something that I've talked about for many years, and that is the fact that I truly believe, even today in 2011, that 99% of the people that are using Simplant and other software applications like it barely use 15 to 20% of the power of that software. And so that's what we're going to explore in the rest of the time that I have with you today. And so we have all sorts of different opportunities to make pretty pictures. The question is, can we utilize those pretty pictures to be able to establish restoratively driven implant dentistry using digital technology? And I believe that we can. And there's a myriad of different software applications that are out there today. The question is, how do we utilize it? What does it do for us? To me, it gives me power. It gives me and all of you the power to be able to look at an image and diagnose what we're seeing. And we've seen a lot of diagnosis over the last few hours this morning. We're going to take that diagnosis from that image or the various images that we're going to look at, and we're going to make a plan, whether it's for a third molar extraction near the nerve or it's going to be for a full mouth implant reconstruction. Then we're going to be able to communicate this information with all of the members of our team. And that, to me, is extremely important. That communication, that link. This is one of the best marketing tools and communication tools that I know of that has affected my practice and my life for the last 20-some-odd years. And being able to communicate this allows us then to finally execute the plan. If we're working in a team approach, if we're doing it one-on-one, it is the best communication tool for our patient and all of the members of our team. And so we have the ability to be able to create for any type of case, whether it's a single tooth implant, whether it's going to be an overdenture. We want to be able to go in there, just like we saw before. We want to be able to see where the denture, where the tooth position is affecting the underlying bone. And Maurice showed a very nice case, or his last case that was with the little issue that we ended up with a little bit more over time here. But the point is that we need to be able to have a radiopaque guide, the scanning appliance, during the scanning process to tell us where the tooth relationship is to the underlying bone. And so if you take a look here at the left part of the screen, you can see 4 locator attachments on implants. You can see ball attachments. We have the ability to choose the abutment, but it's not just choosing the implant site and choosing the abutment. It's being able to locate those implants within the envelope of the tooth or the teeth that we're replacing. And so here we can obviously see that we're going to have an anterior cantilever effect, and perhaps we may want to put the implants in a different position. Using some of the concepts that I've talked about for years, using some of the tools that allow us to do selective transparency, to be able to selectively create a zone where we can see different anatomical structures. This is what it's all about, utilizing those tools to be able to predictively put the implants where they need to go. So it's all in the diagnosis. We need to know where the envelope of the teeth are. We need to understand vertical dimension, centric relation, all of the normal prosthodontic protocols we need to be able to bring together to make this happen. We want to be able to look at the abutment projection through the occlusal table. We want to be able to use some of the transparency tools, and then we want to be able to choose the implant and the abutment that's appropriate for that particular site so that we can have successful results without what I've called prosthetic gymnastics. And you've seen some examples of prosthetic gymnastics already. And so the triangle of bone concept, you'll notice the lift technique over here. And I think this is going down. We're able to lift the lip out of the way with our cross-sectional image. Very useful tool. Just use a cotton roll. Helps you be able to push that lip out of the way. So then we can visualize this triangle of bone, to evaluate the bone that's within it, to look at the cortical plate on the facial, on the lingual, to see if there's a concavity, if there's not a concavity, to be able to then take this one step further. That one step further would be to determine the width and the length of the implant, whether we're going to use a straight design, a tapered design implant, depending upon what you like to use, determine whether maybe a one or a two-piece implant would be appropriate, and then be able to take that information and learn about whether or not we need to graft, and I'm sure Michael will be covering a lot of that information. So these concepts are now being looked at because we're taking post-operative cone beam CT scans. And now we can see where we're placing these implants. Giles was kind enough to loan me this image here. That's right in the triangle of bone concept. This is, to me, where we want the implant. So we were talking about where to put the implant, how far to the lingual, how far to the palatal. Another one from my good friend Barry, who will be talking to you tomorrow. And a lot of the topics are going to be cross-related here. And so you can see the triangle of bone concept allows us to put the implant within the most volume of bone. And now we can validate this with post-operative cone beam CT, as I'm sure you'll see a lot more of in the next day or so. And so having this cooperation between digital technology planning and execution allows us a tremendous amount of information going forward to be able to do this on a regular basis. So the restorative concepts, either analog or digital, is that the tooth position has to guide implant placement. We have to know in advance whether we're going to do screw-retained or cementable restorations. We should know that in advance. We also would like to know which abutment we're going to use, because then we also understand the cost factors in avoiding prosthetic gymnastics. And finally, the ultimate goal, of course, is function and aesthetics. So there is, as I've always said, there is a danger when we are bound by two-dimensional concepts, when clearly today we live in a three-dimensional world. So if we look at axial planning, we're looking at this axial view, we can position an implant into a missing lateral incisor tooth, and we can visualize this, we can make our measurements, we can determine how much bone volume that we have, but this is only one of the views that we need to look at. We need to then go back and look at the cross-sectional planning. And when we look at the cross-sectional planning, we see a lot of information here. And you'll notice that you see a lot of different lines. Well, in this particular image, as we start to look at placing an implant into this site, we can see that there's a green line. Well, that green line I'm going to get to in a moment, because you're not probably used to seeing that green line. And then we like to use an abutment projection so that we can visualize where that implant is going to come out through the body of the tooth. And once we have that information, it allows us all of the diagnostic images that we really need until we get to the next phase. This diagnostic tool is extremely powerful. And so then we go to the three-dimensional view. And that three-dimensional view allows us to use selective transparency to be able to see through these structures, to be able to look at the interradicular space, to be able to look at a virtual tooth, the abutment projection through that tooth, and we can make a determination of restoratively driven implant dentistry. So we can see the root proximity, the emergence profile, everything that we need to see in order to make our plan, even for a single tooth replacement. And having that capability, imagine where we are going from the digital world, going from placing this digitally on this three-dimensional reconstructed view. Can we go from this image directly to CAD-CAM abutments and CAD-CAM crowns? And of course, we've done that already. It's just not been a priority for the companies to invest the time to be able to get to where we could be, and I hope that this new relationship may push us forward. And so having that capability to be able to communicate these ideas with all of our partners, including our dental laboratory technicians, as Marcus very nicely alluded to earlier, allows us a tremendous communication process. So this is where we are, and this is how we can do not only virtual implant planning, virtual abutment planning, and, of course, utilizing a virtual tooth, a virtual wax-up that we can convert at some later date to CAD/CAM related issues. And so here you can see on the left and the right part of the screen, we can evaluate the stock abutments. We can learn in advance if we're going to need a custom abutment. We can see the emergence profile and the depth of placing the implant, as Maurice mentioned earlier as well, because that depth may have an impact on exactly what that emergence profile is going to be. We can use some of our translucency and opacities to be able to visualize the tooth, and then we take that information and we can execute it by doing the surgical intervention on the patient. So this is a cooperative effort in order to achieve restoratively driven implant dentistry using the tools that we have. And then, of course, the invention and the application of stereolithography has been a catalyst for this focus. And, of course, that allows us not only to create a bone model of the patient, maxilla or mandible, but also some of the templates that we utilize, especially those that are fabricated by Materialize and some other companies. And so, as we can see, we also have the rotational position of the implant itself that I call the fifth dimension. That rotational position, flat of the hex towards the facial or whatever the anti-rotational feature is, we need to be able to control it and know where that's going to be so that the scalloped interproximal margin is going to be at the right place when we're utilizing a stock abutment. So having that consistency and repeatability can be done. And how that's done, in my opinion right now, the way that we're doing it most successfully is by combining technologies, and Marcus touched upon it briefly. If we take the three-dimensional reconstructed view that you see here, that's not giving us the most diagnostic accuracy of the surface of the teeth. We need to do an optical scan of either the impression or the stone cast to be able to utilize that information. And if we can take that information then and put it together so that we can, in fact, be able to have the best of both digital worlds, the cone beam CT world and the optical scan world of the tooth position, then we have the best of everything to be able to minimize the complications or the inaccuracies that also Marcus had pointed out as well. So now we can combine these technologies, and that to me is an incredibly exciting part of where we're going. But we've had this technology for a long time. We now need to really try to capitalize it and push forward and allow us to be able to move into that direction and make it mainstream and make it profitable. That's been the biggest problem, is that it takes a lot of time to do these types of images, and that's where a lot of third-party companies have come up to be able to help us. But this gives us an enormous amount of power to avoid complications, avoid making mistakes, and having some of the wonderful technology sorry, I keep going backwards here, but Compartis, linking that, of course, linking this to Atlantis, as we'll talk about in a minute. So taking that optical scan, bringing it together, allows us to be able to combine our planning technologies so that we can position the implant so it doesn't impede upon the root of the neighboring tooth, so it has the right emergence profile, the right angulation that we all want to achieve the ultimate in cosmetic and aesthetic restorations. So merging the data sets right now is the key to making all of this happen. And this allows us to verify the plan before we ever touch the scalpel to the patient. So having this, we need hardware. So Materialize has a universal kit. Dentsply has their expertise kit. We have all of the other companies, 3i with their Navigator kit. Zimmer even has a kit, which surprises me. The universal guide that Materialize has is wonderful to be able to use for various amounts, for various types of implants that you may place. And they actually are introducing a new drill set here at this meeting. And so having that capability allows us to be able to go in there and then accurately take that plan and be able to go to the surgical intervention. And so here we are. We've extracted 2 lateral incisors. These are deciduous teeth that were over-retained. We're going to place our template in. The guesswork is gone. We don't have to worry about whether it's too far facial, too far mesial or distal or palatal. We go in there. We trust the technology at this point that we can utilize, in this case, the universal kit to be able to have our drill guides, and we just go in there, and this, a 12-year-old can do it at this point, just about. You just have to get your drill through the hole. So this is where the culmination of the technologies allows us to have that kind of accuracy and be able to have the consistency that we want. And so some thoughts about abutments, because this is one of the most neglected areas, I think, that we have today. We can plan some of the abutments in advance of the surgery. We have the ability to plan whether we're going to do cement retained or screw retained. We can look at predefined stock abutments or think about custom cast or CAD CAM. We can do this in advance, having this information before the scalpel touches the patient. And does the implant placement affect the choice of abutments? Of course it does. So we need to link all of those solutions together in advance of being able to treat the patient. And as was already mentioned, my slogan, of course, it's not the scan, it's what you do with it. It's how you create that plan. So let's take my closing minutes here. Whoop. Can I go back? Yeah. So here you see a failing dentition. We're going to only look at the lower very quickly. But in order to be able to do this, we want to be able to look at panoramic views, but that's obsolete at this point. We need to be able to look at our cross-sectional views. We need to be able to have tools that will allow us to parallel the implants in cases where we can utilize that parallelization so that we can avoid prosthetic gymnastics. And as you can see, we're looking at the cross-sectional view, and then in the axial view, we're going to plant 4 implants here and 4 implants there. And if we get them all parallel, how much easier is it going to be for the laboratory technician to complete their restoration? And so having this capability allows us to be able to not only diagnose, but to plan utilizing some very sophisticated tools. And having that capability allows us to create virtual occlusions, be able to understand the emergence profiles, be able to avoid the mental foramen and the different positions of any other vital anatomy in that area, and be able to use selective transparency, come up with the position of the implants exactly as we had planned so that we gain correct morphology for the restorations based upon that plan. Having that capability allows us to be able to deliver the restorations going from the pre-operative to the post-operative exactly as we had envisioned, with the least amount of morbidity for the patient. And sometimes we can do this with immediate restoration, and sometimes we do this with a delayed approach. And so having these capabilities allows us to execute that plan to give us the best possible results, depending upon, of course, what is present there originally. Now, years ago, I coined the restorative dilemma. And you'll see that within three-dimensional imaging and digital technology, we can understand the morphology of the teeth that we're replacing. And once we understand the morphology of the teeth that we're replacing, we realize that implants are round and teeth are not. And so having that capability, we need to be able to use some of our tools to look at those socket shapes and be able to put implants into those socket shapes. And you can see all of these gaps that exist. Someone has to make up the difference between that round implant and the abutment that we're going to use that will support the tooth. And of course, in this particular case, we're going to use CAD CAM restorations. And I'm very happy to have been involved with the introduction of Atlantis right at the very, very beginning. And that has been a very exciting part of my life and my career. And now, who knows, it may take a completely different turn. And so having Compartis and some of the other technologies within Dentsply, we have the ability to be able to create morphology for the restorations that we've only been able to dream about. And if you take a look at this result, it doesn't tell you as much as if you look at it from the lingual or the palatal aspect, and you look at that morphology and that soft tissue. Now we have emulated the morphology of that tooth that we're replacing, beautiful emergence profile. This is the kind of cooperation that digital dentistry affords us to be able to correct morphology in ways that we can't with a stock abutment choice. And so utilizing Atlantis for all of these years has given me an opportunity to be able to develop that. And then in conclusion, I want to segue into what Mike is going to talk about. And Maurice kindly mentioned the reduction template. This is a concept that I came up with many years ago, but it can only be utilized with really one software out there. And that happens to be Simplant, because it's really the only tool that allows us to be able to visualize what bone needs to be reduced and how to carefully reduce that bone in a manner that will allow us to be able to deliver the implants even on the same day. But of course, we also know from cone beam CT technology and digital technology that mandibular symphysis is not necessarily a safe zone. I mean, we have all sorts of vessels in this area that we have to be careful about. So digital technology will help us avoid paresthesia perforating into these vessels and causing, hemorrhagic episodes where people have actually died. So we need to be able to understand what the anatomical limitations are in the area that we're working with, and we have to be able to visualize all of these views with the technology that's at our disposal. So the bone reduction template is actually pretty simple. It allows us to be able to visualize the bone that needs to be removed, and using some of the sophisticated tools within Simplant and even their oral and maxillofacial surgery component, we're able to go in and actually demonstrate how we can remove that chunk of bone and be able to very carefully plan that with another type of template. We can go in, we can reduce the bone, we can do it with tremendous accuracy, we can go in there and we can visualize during the procedure where the bone needs to be removed, how it needs to be removed, and then we can place the implants in a flat, nice, ideal receptor site. So we can do this, in fact, sometimes all in one procedure. And this was actually something that we have published. But having the template, and just so that you understand, this template is only as good as your plan. And that's why I look at the diagnosis. That's why I emphasize the diagnostic capabilities that we have, because having that diagnostic capabilities are completely different from one cone beam CT machine to another, from one software application to another. There is no comparison between anything that is out there today and what you're seeing on some of the images that I'm showing you right now. And so having this capability, we also need the hardware tools to deliver the implants exactly where we have planned them. And we have them. This has been proven. But there are still some complications and inaccuracies that have been pointed out. So here you see a stereolithographic model here on the right-hand side. Look at the amount of bone. It happens to be about 10 millimeters worth of bone. You can visualize these videos on Dental XP if you'd like. This is a full lecture that I have provided for them a couple of years ago. And as you can see, this is the bone reduction template in place. We know exactly how much bone needs to be removed. It becomes very simple to go in there. Today, if I were to redo this case, I probably would use a piezo surgery unit. I tried working with them for 3 or 4 years to develop special tools to do this. So far, we haven't been able to do it, but we're still working on it. And so having that capability allows us to take that 10 millimeters worth of bone and be able to very carefully remove that bone very succinctly, very nicely in a procedure that takes so much less morbidity for the patient because we know what we're doing, and then we can go in there, put a bone-borne template at the same time, and be able to then put the implants in. That you can see on Dental XP with the whole entire video. And so the immediate restoration for this particular case, we actually did. We put these implants into an immediate load situation. This was published back in 2006. It's 5 years ago. We're able to go in there. And then, of course, we have other technology that was already mentioned. CAD/CAM technology to create the bars, to create the metal substructures. We need to be able to put implants in parallel to make our life so much easier. For me to look at all implants going at different angles is not, what my laboratory technician wants to see. So in conclusion, can we go from cone beam CT to abutment fabrication? Absolutely. We've done that before. We've done that. It's been published. What happened to the technology? We need to capitalize it. Digital CAD/CAM dentistry is the future. I believe that it should be used as a collaboration between the skill of the laboratory technician, state-of-the-art software applications, the surgical specialist, the restorative specialist, and the future vision of the dental implant industry. And I can tell you what I've seen here today and what I saw 2 years ago with Dentsply. They have a vision. I'm happy to be here to share some of that vision now that they own Atlantis, which is what we use to be able to do the only cases that we work with Materialize to produce CAD/CAM abutments without impressions, going directly from cone beam to the final abutment we were able to complete with Materialize at that time with Atlantis. So in conclusion, 3D planning often starts before the cone beam CT scan is taken. We need to understand all of the views for every site that we're doing. We want to be able to practice true restoratively driven implant dentistry. We can use third-party software that's out there today and companies that help us to do some of the segmentation that I'm showing you. It is the best marketing and communication tool that I know of in our industry. We need to take the guesswork out of the equation, take your time in planning, but the whole ball of wax is that this helps us in our diagnosis, the treatment planning concept. It has really been a wonderful honor for me to be here today. I really appreciate the time that was given to me, and I hope the next day and a half will be wonderful for everyone as well. Thank you so much.